So a table I wanted to mention to you that's going to tell you about all these insulin is 39.2 on page 674. Really good table that has the names as well as short, intermediate, or long acting. In addition, picture 39.8 will cover the various locations on the body where you might inject insulin. So adverse effects. Actually, let's talk one more thing about insulin. It can be in a vial or it can be in a pen form, which is easier for the patient to inject. In a vial, they have to draw it up and they have to be able to see this tiny little syringe marking. So especially as patients get older and they have some of that visual damage from, poor glucose control, they can't see the syringe as well. On these pens, all they do is dial to a number and then stick it in and then push down on a button. It's a lot easier to use, a lot more convenient, a lot harder to screw up, so that's why sometimes these patients are put on those pens for convenience purposes. They work the exact same way, it's just a matter of a little bit of a different route of administration. Side effects of insulin, exactly what you think, hypoglycemia. Also, insulin causes fat redistribution throughout the body. It can cause site reactions where it's injected, allergic reactions, blurred vision, and abscesses, which is why we rotate the site that we are injecting. We always want to have, we talked a little bit about glucagon earlier being used in emergency situations. A lot of times diabetics will have a piece of candy or orange juice candy in their house, in their purse, in their pocket, car, whatever, just in case they can kind of feel themselves getting low. They can take that and bring their sugar up until they're able to either adjust their insulin or eat a full meal. One more thing we want to talk about. We talked about injecting. There are pumps for for diabetics who are insulin dependent that actually are permanent. So they get inserted through a sub-Q port, or they set up basically every time they change it, they'll put in a little injection, take the needle out, and now they've got a direct route under the skin. And that pump will actually test the blood sugar itself and give the amount of insulin needed, or the patient can control that via how many carbs they've taken in. So there's a couple different options with those pumps for control. But that is for somebody who is usually type 1 diabetic and requires insulin basically to stay alive. I don't think they covered the pump too much in this book. If you have any questions, please let me know. I'd be more than happy to find a resource to give you guys more information. Moving on to administration. Insulin is usually administered 15 to 30 minutes before a meal. For long acting, it can be administered at the same time every day, usually again at bedtime or first thing in the morning. And the needles, you might think that injecting yourself could be pretty awful every day, and it can be. However, the needles are usually pretty small, pretty thin, and short, so they go right under the skin. They actually had us do an injection in a class one time on ourselves, and I spent the whole class freaking out because I was worried that it was going to hurt. And in reality, it didn't hurt. I couldn't even really feel it, but it made me feel a little bit better. But I still kind of felt, if you feel that empathy for people who have to stick a needle in themselves every day. Drug interactions with insulins, salicylates, beta blockers, adrenergic blockers, MAOIs, and anything that's going to deplete potassium. Insulin shifts potassium into cells, so that means our serum potassium, the amount available in our bloodstream, is going to be lower, so we may have to replace potassium if we are in addition giving them medications that deplete potassium. So let's move on to amylin analogs and incretin mimetics. These are the other injectable medications that are not insulin. And if you remember, amylin decreases glucagon secretion and slows gastric emptying. So that, over time, decreases post-meal glucose load and the amount of glucose that is released from the liver. It also sends full signals to the brain, so patients might eat less. Similan is the amylin analog, and the generic name for Similan is pramlintide, and it comes in a pen. Just like those easy-to-use insulin pens, it's the same exact idea. You dial up your dose, you insert, and push a button. The dose for Similan is usually 15 to 60 micrograms before meals, and that's for type 1 diabetics. Type 2 diabetics require slightly more, 60 to 120 before meals, so that's 3 times a day. And this is not to be used as monotherapy. Usually it's in combination with other therapies. So it has similar side effects to insulin, nauseousness, weight loss, however, and it may lead to decreased insulin requirements, so you may need to adjust your insulin dose. contraindicated with patients because it's slowing down gastric emptying. It's contraindicated with patients who have any sort of gastroparesis or are taking drugs known to delay gastric emptying, such as anticholinergic drugs. Incretin mimetics, we have two: exenatide, which is the brand name is Byetta, and liraglutide, which the brand name is Victoza. Again, convenient pens, awesome, easy to use for our patients. Exenatide is dosed at 5 micrograms under the skin, sub-Q, twice a day, can go up to 10 micrograms. Liraglutide or Victoza is 0.6 under the skin every day, up to 1.8. So if we talked about potency, 0.6 is a lot smaller than 5, so we know, and it's only given once a day for liraglutide, so we know that liraglutide is a lot more potent than exenatide. This medication can be used as an adjunct to diet and exercise in type 2 diabetes. It delays gastric emptying, inhibits glucagon secretion, and increases the amount of insulin after a meal. It's contraindicated with oral secretagogues, which we're going to cover in a little while, because that can cause greater hypoglycemia, and it's not for use in type 1 diabetics or not for use with patients using insulin. It's really an adjunct to the oral medications. Adverse effects are pretty straightforward: nausea, vomiting, diarrhea, headache, dizziness. Byetta can cause acute pancreatitis. I believe there is a black box warning for that, and Byetta again is exenatide. Liraglutide or Victoza can cause thyroid tumors in animals, however that has not been absorbed in humans. Moving on to the oral anti-diabetics, and these are always used in type 2 diabetic patients. Because we have to replace insulin in type 1, we usually don't use oral medications in type 1 diabetes. So the secretagogues, and there are two types: sulfonylureas and non-sulfonylureas. The sulfonylureas include glimepiride, glipizide, and glyburide. Those are the ones you're going to hear about commonly today used on the market. Old ones include names like chlorpropamide, tolzamide, or tolbutamide. Those are no longer used as much because they required more dosing, or maybe they weren't as reliable or had more interactions. So when you hear about sulfonylureas, mostly we're talking about those G1s: glipizide, glimepiride, and glyburide. They're usually dosed once to twice a day, depending on their length of duration, and that is covered on page 684, chart 39.4. Helpful for you to see how long that medication is going to stick around, as well as it covers all the other medications we're going to talk about, and it also covers their doses. Okay, so the non-sulfonylureas that are secretagogues are naglinides, and we have repaglinide or Prandin and nataglinide or Starlix. Same actions as above, but more rapid with a shortened stimulation of beta cell. It's dosed more often, so it's not as convenient, which is why you more often than not see patients on glipizide, glimepiride, and glyburide. And what these medications do is they cause a release of insulin. So the name secretagogue should automatically make you think, okay, we're secreting more insulin. So the adverse effects of these medications, of course, hypoglycemia is going to be one of them. GI irritation, nausea, vomiting, diarrhea, weakness and fatigue, as well as weight gain and sensitivity reactions. Contraindications, known hypersensitivity, type 1 diabetes, moderate to severe liver or renal disease. And for drug interactions, you're going to want to take a look at table 39.5. Our next class of oral medications is alpha-glucosidase inhibitors, which inhibit glucose absorption. So they're going to kind of keep the glucose in the intestine and cause it to end up being excreted. The names for these medications are Miglatol, which brand name is Glycet, Acarbose, whose brand name is Precose, and again, these interfere with carb digestion. They decrease that glucose spike that happens after a meal, usually used as combo therapy, and are taken with each meal. Adverse effects include GI, flatulence, diarrhea, and abdominal pain. They're contraindicated when a patient is in DKA, as well as if a patient has any sort of bowel disorders like irritable bowel syndrome or absorption disorders. Obviously, if someone's hypersensitive to the medication, we wouldn't want to give it. And with Acarbose or Precose, we don't want to give it to patients who have cirrhosis. Okay. Moving on to our last three types, biguanides. There's only one, metformin, and it is the most common diabetes medication on the market. usually given twice a day with meals. It decreases liver glucose production and intestinal glucose absorption. So if we can decrease both of those, we are essentially lowering the blood sugar by just keeping the glucose in the intestine and again excreting it. It enhances glucose utilization in tissues, which means more of that glucose is able to get out of the bloodstream and into the cells. Like I said, given twice a day, usually at 500 milligrams, can be given up to 2,500 milligrams a day. We change the dose in patients who have renal disease. A creatinine of above 1.4 in women or 1.5 in men means patients do not take that medication. Adverse effects include diarrhea, nausea, vomiting, and flatulence. Black box warning for lactic acidosis. This is rare but fatal with this medication. Lactic acidosis is a buildup of lactic acid. So we want to look out for patients, after patients have adjusted to the initial, those adverse effects I mentioned do go away. So after they've adjusted and they're not suffering any of those adverse effects, we want to keep an eye out for respiratory or abdominal distress, as well as fatigue, myalgia, which is muscle pain. That'll tell us that patient is building up lactic acid and we need to discontinue the medication right away. So contraindications for metformin include DKA, renal disease, giving the medication within 48 hours after giving contrast dye, as well as alcoholics. We want to avoid this medication in alcoholics because it can actually increase their risk to build up lactic acid. Insulin sensitizers, the long word there is thiazolidinediones. Just remember, if it says glitazones, those are insulin sensitizers, and they make our body more sensitive to insulin. There's two on the market, pioglitazone and rosiglitazone, Actos and Avandia. They enhance peripheral cell response to insulin, which means more glucose out of the bloodstream and into cells. Adverse effects include diarrhea and nauseousness, and they can cause fluid retention as well, so we worry about patients who have CHF. CHF causes a buildup of fluid in the body, so we want to make sure that we are not assaulting the patient with more medications that are going to cause the same problem. Avandia has an increased risk of cardiac events. That's our rosiglitazone. It actually requires a REMS by the provider, which is a risk evaluation mitigation strategy, meaning it can't be used unless the provider is going to counsel the patient and fill out specific forms to be able to prescribe that medication. Last but not least, so we need to get through this in 2.5 minutes, DPP-4 inhibitors. Remember before we talked about DPP-4 stops incretins, and incretins are good. They help get rid of blood sugar. So DPP-4 inhibitors will stop DPP-4 from taking away the incretins. These medications include saxagliptin or Onglyza and Januvia, which is sitagliptin. The brand names are Onglyza and Januvia. Generic names respectively are saxagliptin and sitagliptin. And these are kind of new on the market, and they're actually being used a lot. It can be used as mono or combo therapy. And the adverse effects are nasopharyngitis, upper respiratory infections, headache, and they require dose adjustments in renal disease. So that covers chapter 39, last chapter of the week. Contact me with any questions, and remember, at the end of this week we have weeks 1 and 2 due by Saturday at midnight. If I see that you haven't done this stuff on Saturday, I will be contacting you personally. You will hear from me, whether by email or by phone call, depending on what I can get done at work. I want you guys to get this work in. In addition, don't forget your forums for week 1 and 2. So we have forums for week 1 and 2. We have Connect, homework, and test for weeks 1 and 2. And we also have our drug project part 1. Don't wait till the last minute. Get it done now. Then you can relax for the rest of the week before we move on to week 3. Hope you guys have a great weekend, and I look forward to hearing from you. Bye.